So now it's my pleasure to introduce Jako Nice from South Africa, an architect. I should have mentioned this earlier that for like most things, it takes a village, and it's a multidisciplinary approach. We have our engineers, we have oftentimes it's infection prevention and control at the facility level is done by nurses. We have engineers, and we need our architects to make sure that we have a building that is safe and effective. So, Jako, over to you.
Thank you, Kerry. Good morning, bonjour. Okay, so I'd like to speak to you this morning about a couple of things, and you will see some repetition between the slides and between the speakers, and I think that's important. In part with what Kerry actually just said now, is the relationship between different fields and how we actually need to be working more closely together from a transdisciplinary perspective as opposed to own silos. And the goal is to try and sort of bring that to light in this presentation. So we're going to speak about IPC and the built environment in particular, some factors, and I'm going to use a case study, which is primary healthcare, which is going to be linked to the exercise afterwards as well. We'll be unpack, and you'll get the opportunity to unpack that design, and then sort of finishing off with evidence-based design. But what I want to do is, and I always start with the slide because it just only brings context very quickly. These are absolutely random numbers. Well, they seem random, but they're not. The first number is life expectancy if you're living in South Africa. If you are living in France, it's about 82 years. If you are living in India, it's 70 years. The average world life expectancy, global one, is 73. South Africa, it's 65.3. It's a little bit lower. Of that, 86% of the time you'll also be spending indoors, which is why this is really critically important. And of that, you'll be at home, about 70%. You'll be sleeping away very much of that. And then, depending on what you do and how involved you are, you'll be outside for about 8% of the time. So why do I say all of this? It's because the environments we design and plan for are extremely critically important, and how we clean them, how we deal with them, how we manage them is critical. And it's sort of exacerbated because of the image that I'm showing up here now. What we're seeing currently, globally, we've got 7.5 billion people. 50% of the people are urban residents in major cities around the world. And we are expecting that 50 is going to move up to 67%, 17% jump globally in the next 30 to 40 years, which is immense. In Africa alone, in the next 30 to 40 years, we're seeing a 300% increase in urbanization. So what we've experienced as COVID is just the beginning. And many other things are yet to come, because we are going to be living in congregated spaces closely together, and it's how we manage and deal with these environments. Paul alluded to this earlier when he spoke about, and briefly showed about Florence Nightingale. What I'm trying to share here is the sort of one of the first and most important probably studies. Anecdotally, she didn't actually know what she was doing or the intention of what she was doing at the time, but it started to show that we get ill mostly by interacting with people around us, and she did this through the Crimean War and her assessment. And what we know today, and we call it today the same thing, but in modern terms, nosocomial or healthcare-acquired infection. And that's not just, and this is an important point, it's not just healthcare environments, it's all building environments, whether it's a school, whether it's in a hospital or clinic, whether it's at a old care or feral care center, if it's in a mall, if it's any place where there's a congregated group of people. So I'm assuming many of us know this, and this is why you're going to have the slides afterwards. The transmission or infection cycle. But what I want to allude here very specifically is where the built environment comes to play. So the first part, we need a causative agent. That, unfortunately, is found in the built environment. It's either there or it's you bringing it in there. And the second one is reservoir. So it's there, you bringing it in there as the reservoir, or it's in the corners where there's very little ventilation, or it's on the surfaces that hasn't been cleaned, or it's just hanging in the air like droplet nuclei for many hours because there's no ventilation. And then you need an exit portal. Fortunately, that's not in the built environment, but you need a mode of transfer, and that is And that could be no windows or windows. It could be through air surfaces. It could be many other forms. And then a portal of entry, which is then us as the persons moving into those spaces. And again, how we design and plan and make people move through environments affects that. So it's pretty much fused in the way that we see buildings and the way that we experience spaces. There's obviously multiple routes of transmission, and I'm going to focus just on the middle two, which is droplet and airborne. Droplet meaning it's moving through the air. It could be short distances, up to 1 meter for heavy droplets, and then droplet nuclei, which is very, very small, less than 5 micromillimeters, and then it's be able to move through air currents, and it could be, which is where we found TB and where we have found now COVID and other. So why is this important? Because in the study I did back in South Africa, where I looked at 2 different hospital environments, defining the microbiome of those spaces in order to understand the risk, there's clearly evident that there's 2 different populations, communities there. One is the surface community and one is the air community. And they actually change seasonally, but they're both present and they both can affect us or infect us. So it's really important that we actually understand that how buildings work and how the spaces function affects these communities, and these communities are the one that either carries or on the other side actually makes us healthy. And I'm going to just leave that there because there's a whole different discussion on that. But what's important from an architectural point of view and from a design point of view is that, in my interest in spatial analytics, is that we actually need to start understanding how places are used, work, how we move through them based on how we design. So what we did in this study, we looked at the layout of the building, and then we actually went and programmed and looked at how people actually use it based on the way it was planned. And then looked at where was the highest quanta of organisms in different environments over different seasons to understand what was the movement of that and how did that change, and what was the potential rates of that. So, and we can see through doing that, we can start to understand how these communities shift, move, and potentially IPC gaps in the system. So very quickly, I'm not going to go through this algorithm, but the point is, the critical parts of this is that there is dose and sites of contact and time of contact, and that's linked to environment, the built environment. It's how long are you in a space, it's how many people are there that you congregate or allow to be in that space, and it's how much time you will be spending in that space. And that's actually direct factors linked to the probability of infection. So when we look then at the basic reproductive number, and we look at whether that is an airborne contagion, whether that is surfaces, so if we move it from Ebola all the way through up to airborne, which is why airborne has a much higher potential for cross-infection. If you look at measles, that's 18 potential people that could be infected. Suddenly when we look at that probability of infection, and we look at the built environment, we realize, and I'm hoping my repetition of the comments become evident, that it plays a major role in the way that we either stay healthy or get ill. I mean, these are really interesting 2 great diagrams explaining the comparison between tuberculosis and COVID and really the similarity between the 2. But the way that droplets move, and this was done by Coleman et al. In a very recent study, but really we find the similar movement of droplets and airborne microparticles. So large droplets were settled within 1 meter, and then smaller ones depending on the relative humidity and the airflow in that space. We made the observations this morning, not really feeling a lot of airflow in this space, but again, I'll leave it at that. Anyway, so what Paul also mentioned, which is really important, is that the answer is it's a basket case. It's not just one. I can't just have, as Mattia was speaking about PPE, I can't just do UVGI or GUV or appropriate design planning. I can't just do administrative controls. And this is one of the few, unfortunately, there's not a lot of studies out there, and I've really tried hard to look for more studies, and I can't find more studies. But this specific study actually shows how a multiple collection of IPC approaches as a collective, as a basket, actually reduces infection. So it's not, if I remove one of the parts, most likely, in fact, definitely, it will fall apart. So it's really important that we actually consider, and that's why looking at and Mattia also spoke about an interdisciplinary team That's why it's so critically important that there's a team that's of different perspectives and fields involved. From the IPC hierarchy, obviously we speak about administrative controls, PP, and then when I spoke about environmental controls, I'm just going to show a few practical approaches. So when we're looking at designing and planning facilities and hospitals and so on, obviously we try to design out the problem. And that's either by separation, seclusion, or that's through isolation. And isolation is not separation. Again, I'm going to leave it at that, because I've seen way too many examples in many of the facilities I have visited, not just in my country, but globally, where they have termed it a separation or isolation, and clear it's just a wall with open ventilation, and to the next space, to the next space, to the next step. And that is not isolation. And then systems proofing, or people proofing, we would call it. And that is really important. We actually need to sort of people proof the problem out, because we can make mistakes. And often, let's say it's a cold environment, and the nurse at the nurse's station is cold, and it's legitimately, it's winter, so it's cold. So I'm going to turn off the ventilation because I've got a switch behind me. So what happens? Suddenly she's at risk. So what do? I don't design the switch there. I remove it. I put it somewhere else. So we design out the problem, not by removing the comfort, and I'll get to that just now, but by making aware of the potential risk in the environment. And Paul's image of the tsunami is a perfect example. It's when I know the risk and I know how to deal with the risk, then I might just think about it quite differently. And then obviously also building surfaces, materials. What are the material choices I use? Do I use copper? Do I use non-impervious surface material that is easily cleanable? And then importantly is assembly details and workflows. And in the exercise afterwards, we're going to look at some of those workflows. And how do I prevent cross-traveling within design? Because that I can design out. That's possible if it's carefully considered through an IPC point of view. When we speak of ventilation, obviously there's a number of other concerns besides just ventilation and moving air and reducing and diluting it. But it's also this whole concept of thermal comfort and your perception of thermal comfort. And that changes from one country to the next, and depending on environmental and climatic conditions. But important is the social and the physical factors, or the psychological factors, and how you manage and deal with that. Richard ETTi has written much work on this, where you as the user are able to change, or should be able to change the environment. But with the fact that we need to understand that there is a risk involved. Obviously, when we look at from an occupied point of view, the first choice is always natural ventilation, because it's free, it's open, and I can design it right. Should I design it right and lay it out right, I'll get the best benefit for my input. And then it moves up on the chain to hybrid, eventually towards fully mechanical. In the same way that when it's fully passive, it's the occupants and the equipment is adaptable, and they have the opportunity for change, which actually reduces their stress, which then also, that's the whole salutogenic concept, so it actually reduces and improves the potential for getting better. As I move up that chain, less they can change, and it actually causes other factors. Just some principles: single-sided being the top left, being the most ideal. Top right, it's getting a little bit worse, not really having ventilation. It's not really single-sided. I've got a corridor splitting it. The bottom, suddenly I've got two double corridors. I've got a corridor, so I've got double loaded space. So I'm not really getting cross ventilation, but maybe I can make a plan. And then at the bottom right, and this is typically the notion of design and layouts, and many of your facilities might look like that, spaces you've been. Suddenly I've got almost zero ventilation, not even cross ventilation down the passage anymore, because I've added these two spaces on the far right and I've prevented the air from moving. So when I start changing space design, and often we do that when we retrofit spaces, we say, but I want my room to be in the opposite corner because I think that's more accessible, let's say, for TV patients. And you have to ask the question, well, what is the greater impact on the layout and the planning? And how is it going to affect that potential risk and transmission? So the case study I wanted to use is primary healthcare. Primary healthcare in our country and in every other country is very similar in the precepts, and that's why I'm using the constants. The constants being the patients, they're all there. The disease burden may vary. Principal patient flow, so the constant. The critical care flow is constant, and then the variety of care and specialization is most often constant, linked to the disease profile. But the variables is country-specific profiles. The variables is funding, the variables is population support, etc. So there are variables, but there are principles that are consistent regardless of where you are globally. But designing for that is complicated. It's not simple. So a couple of practical approaches. So this is the typical program of a primary healthcare center. I'm not going to get into the depth of it, but just by looking at the basic layout, there's a lot of moving parts. And we need to think about all those moving parts and the sub-elements of those parts. So when we look at the design principles within that, look at it, access, circulation, security, and then this thing which is very rarely discussed, which is infection control. It normally gets, once the design is finished, once the consultants are left, what are we going to do? How are we going to make this building safe? Well, it's actually too late. Now we have to retrofit everything to try and make it work, as opposed to fusing it as part of the design process. And I've had too many consultant meetings where this is the case in the end. But all those parts actually are critical in the consideration of design and planning towards the healthcare facility. This is just some of the patient flow processes. I'm just going to put this up here. I'm not going to go through the detail of it, but it's important to understand how they work, how the patient flow works, and how that process works. Then the multiple different zones within facilities, the access restriction and thresholds, who gets to go where, why don't they get to go there, and also that affects potential infection and potential contact for healthcare workers and or staff, other staff and or patients. And then further zoning in a bit more detail. This looks at inpatient and how that connects to other facilities and other spaces. But what's important, and this is sort of my personal interest, is the microbiomes of buildings. It's really understanding the unseen and how the unseen of the building is affected by how we design buildings that we can see. And from many of the studies and the studies I've done is our behavioral choices has a direct impact on the infection potential and the infection control of these environments. And ventilation is a source driver. I had a facility that I was doing one of these assessments. Some of the rooms were absolutely closed. There was only mechanical ventilation. It had no outside windows, so it's a perfect space for many things. And then on the opposite side, there was a building or a large triage room that had open windows, completely open windows, but also had a mechanical system. What we found is that 65% of the organisms were found in both spaces, with very little variation between the two. So the mechanical system that was working in the background was actually causing everything just to be distributed equally throughout the entire system, the entire facility. So the question is, how do I deal with, is that the appropriate ventilation system, and what is or what is not working? So the ventilation methods account for greater variance in airborne bacterial pathogenicity than ventilation rates alone. But what's interesting is that there is a sort of a hidden design element that was, from IPC point of view, that was sort of revealed in the study, is that the complexity of the built environment, when we have to design buildings, there's two elements to it. One, we can have a building is designed with a program up front. That program is what was agreed for in advance, and that's the rooms and exactly the way the rooms are laid out. And then there's the way I use the building, which is not often related to the way it's designed. So when we say something is a weak plan, it's the way that I use the building, or the way that the building is designed. A strong plan, from a programmatic point of view, is the way that the building is then applied or used in actual fact. And what's interesting about healthcare facilities fit into the strong side. It's a strong program. It's program driven. This dynamic element is actually causing a lot of IPC issues, and we actually are not dealing with any elements of that. This dynamicness of the pattern moving is actually causing potential gaps, and because we are not considering it. I've just showed this example here, which is a clinic back in South Africa in Cape Town. It's a really good example of what we call a salutogenic appropriate building, and it considered a lot of natural ventilation, open windows. Not that example there, but I can access the outside, I can see the outside, I can get natural light in the space. So I'm reducing stress, I'm reducing a lot of issues. So Machi spoke about risk assessments, but as we're going to do a bit later in the exercise, we're going to look at critical control points, and we're going to look at how we deal with risk in specific spaces and how we plan and design around that. And then what's really important right at the end, as I close, is evidence-based design. There is way too much information out there for us to have it to make mistakes. And we need to actually start looking at the evidence and then question why some people are making some decisions, and then go back to what the evidence says, and then make the right ones next time. Thank you.